Good evening, everyone. I hope you can hear me and you can see me. Welcome to the 14th episode of Master Techniques webinar. My name is Maneesh Bhatia. I'm a consultant at University Hospitals of Leicester. On behalf of the Education Committee of BOFAS, I would like to welcome you all on board. This very popular Master Technique series, we organize it about once every 3 months, and we usually have two speakers, and we pick up a topic which is of interest to most of the foot and ankle surgeons. So tonight's topic we have chosen is flat foot, not just flat foot, but progressive collapsing flat foot deformity. It's an interesting topic, and it's something which we all debate about: what causes it, uh, how to treat it, how to classify it. And in this evening session, our two guest speakers will help us to understand the basics of the pathophysiology and the treatment. So, our first speaker is Mr. Chandra Pasapula. He's a consultant foot and ankle surgeon at QE Hospital, Kingsland. He has done a fellowship just before me when I started in Cambridge. So he was a previous fellow, and I saw lots of letters of Chandra at Addenbrooke's Hospital. Chandra has an immense interest in the spring ligament and the pathogenesis of Flatfoot, and he's going to share today his view, his understanding, and we'll learn from Chandra. So, Chandra, please start sharing your presentation once you're ready. Thank you, Chandra.
Hold on. Yeah, sorry, just getting it going.
No problems. So while Chandra is doing that, oh, he's done it now. I was going to say, yeah, after Chandra, we have our second guest speaker, and then after that, we'll do a discussion session. So all the questions, please put in the Q&A. Okay, over to you, Chandra.
Maneesh, thank you very much for that introduction, and I suppose I'm very grateful to be on this sort of platform. Today, I've been asked to talk about the importance of spring ligament in PCFD. The title of my talk is Axis and Ligaments. When I looked at this subject and I put PCFD into PubMed, what it did was return 1,600 articles. And no one person can have complete knowledge over this subject. And I certainly didn't read 1,600 papers for this talk. So the focus of my talk is going to be on the spring ligament and potential sequential ligament failure, the subtalar axis and ground reaction forces, and a test for spring ligament laxity that I think we can test for, and the principal sort of rationale for treatment. I still believe PCFD is still primarily a disease of ligament, and it's ligament laxity that leads to joint deformity and joint degeneration and stiffness. And it's that ligament laxity that leads to tendon overload, dysfunction, synovitis, and rupture of those tendons. But in order to progress, we need to dispel existing dogma. And there's several ways we can do this using rheumatological evidence. We can use EMG evidence. But one of the best ways of doing this is to actually look at stage 2 disease. And what was stated was that the tendon lengthened and led to a dynamic instability of the arch. But if you take a tendon and lengthen it, what you're effectively doing is introducing slack into that system. And if you put enough slack into that system, that's like detaching it. And we do that when we do our tib post tendon transfers. And if you look at the long-term outcome of patients who have had tibialis posterior tendon transfers for both drop feet and pes cavus, what we're finding time and time again is that the foot doesn't necessarily go into planus despite 8 to 10 years follow-up on some of these patients. So if the lack of tib post doesn't induce planus, what's keeping the arch up? And Huang did a study where he was able to use strain gauge potentiometers to measure foot length and arch height. And what he found was when sectioning the long and short plantar ligaments, the plantar fascia and the spring ligament, 63% of arch stability was still maintained. But out of that 37% loss of arch stability, only 14% was due to the spring ligament. So if only 14% of arch stability is due to spring ligament, can it be important? Well, we know that the spring ligament is a very resilient structure, and the Japanese were able to show using ultrasound on transverse sections, the spring ligament had very little strain that developed. But it does develop strain. And when you load the spring ligament, it's an elastic structure that develops strain. And when you unload it, it then goes back to its original position. But Crary was able to show that in the absence of plantar fascia, the spring ligament undergoes plastic deformation. So the plantar fascia is hugely protective of the spring ligament. In the absence of it, it will go into plastic deformation and permanent strain. And Chu and Meissen were able to show that cyclical loading is very important as well. So they were able to take feet and statically load them. Even if you statically load these feet to 3,000 cycles, you do not induce a planar valgus model. But when you section the spring ligament and the plantar fascia, you generated some elements of planar valgus, but it was with that cyclical load into 3,000 cyclical loads, what they're able to do is identify a radiographic evidence of a planar valgus model. So it's not just the fact that the spring ligament sections to induce visible planus, you really need to cyclically load it to induce that first ray to fail. But can the spring ligament alone cause problems, sectioning alone cause problems? And I think this is one of the most crucial studies done by Jennings. And what he was able to do was use positional potentiometers to look at peritalar rotational changes that occurred when you section the spring ligament. And what he was able to find was when you section the spring ligament, he was able to induce non-visible peritalar rotational changes without visible evidence of a planar valgus model. And he correctly concluded that the spring ligament did function as a linchpin to support that medial arch. And we were able to show in a study where we looked at patients who had pronation external rotation stage 1-2 injuries and supination external rotation ligamentous stage 4 injuries, i.e. patients who had complete deltoid rupture. What we found was that the deltoid firms up, i.e. they had a negative anteromedial draw test, but the spring ligament was still loose. Either had a lot of talonavicular abduction laxity. And this is crucial because for the first time in vivo, we know when 0.0 is, when the injury occurred. And what we found was that the first ray destabilizes in patients who have been loading it greater than 6 months, and patients that hadn't been loading it for greater than 6 months still had a stable first ray. And in 75% of patients had a reactive tib post. So the spring ligament is crucial in sort of protecting that first ray. So if we know when the spring ligament fails, could we be testing for it early? And the answer is yes. But so really, it doesn't matter whether it's the plantar fascia that becomes weak or the spring ligament becomes lax. Pressure on that spring ligament with these extrinsic pressures will ultimately result in talonavicular subluxation, which will then generate an altered subtalar axis, opposing internal foot moments, and increased reactivity of muscles. In particular, the tib post is the one we go for. And why does the tib post react? Well, I think it's really important to appreciate the subtalar axis. And the subtalar axis closely follows that central path of the mid-talar body and the mid-talar neck. And it's closely linked to talus position. It's offset from the floor by about 42 degrees. But in pronation, the subtalar axis internally rotates and plantar flexes, and in supination, it externally rotates and dorsiflexes. But it's not fixed, and it's dynamic throughout the gait. It varies between people, sexes, the morphology of the subtalar joint. So, and it's very clinically hard to judge. And there are tests for it, but I'm not going to go into it in this particular lecture. But in mid-stance, the subtalar axis roughly points towards the hallux. And in terminal stances, the tibia externally rotates, the talus externally rotates, and locks the forefoot. You generate a net inversion moment through the ground reaction force that acts through your stable first ray. And roughly 60% of the force goes through that stable first ray, generating that net inversion moment. But with spring ligament laxity, what you're doing is decreasing that arc of external rotation at the forefoot, diminishing that ground reaction inversion force. And with destabilization of the first ray, you're transferring the load to the second metatarsal, further diminishing that inversion ground reaction force. And with significant spring ligament laxity, you end up generating an eversion ground reaction force, which tib post just simply can't act against. And if you look at the anatomy of FDL, which runs a far more straight line course, the strongest fibers of tib post start far laterally, and insert as far lateral as the fifth metatarsal base sometimes. And in terminal stance, the subtalar axis is externally rotated, and much of tibialis posterior acts medial to the subtalar axis. And therefore, you generate a net inversion moment, particularly at the navicular. But with that diminished external rotation of that subtalar axis, much of the anatomy of tib post now lies lateral to that subtalar axis, and you're diminishing that net inversion ground reaction force that develops at the navicular. And the end result of this is the muscles have to do more work. And it's not just tib post. Adrian was able to show that there was increased activity in soleus, and in order to compensate for first strain stability, the abductor hallucis and flexor is also increasing in its activity. So a lot of muscles are trying to compensate for this functional loss. So when does tendon reactivity occur? Because the reality is, if the tendons are not active, they cannot be overloading. So we've got to look at where peak overload occurs. And if you look at maximum voluntary contraction during the gait cycle, both soleus and tib post maximally contract at about 48% of gait cycle. In mid stance, where we examine the foot, soleus and tib post are only acting at about 20-30% of their activity. They cannot be overloaded. It's at this 48% we're going to be generating this overload when the tendons are active, not inactive. And what's happening at this point, what we're seeing is that the foot is in terminal stance, the contralateral foot's off the ground, the entire weight's going through that foot, ready for forward motion, and the subtalar axis is now parallel to the floor, maximally localized to absorb that ground reaction vector around that subtalar axis. So it's in a perfect position to take that inversion moment. Perfectly designed. So at peak tib post activity, the contralateral foot's off the ground, we're at toe off, the subtalar axis is parallel to the ground, and at this point, the forefoot is fixed to the ground. The foot can't invert because tib post, although it acts as a net inverter, the foot cannot come off the ground at that point. It's actually fixed to the ground. So what really happens, its primary action is to externally rotate that tibia. In doing so, you're externally rotating the talus. In doing so, you're externally rotating that subtalar axis. And therefore, you're generating that net inversion moment, which then drives that linkage to the heel. And along with the tendon of Achilles, inverts that heel. And that's all well aligned. And this is a diagram taken from a sister paper, but that middle foot also shows that soleus, which constitutes about 62% of the transverse muscle bulk, actually rotates internally to insert on the medial side of that calcaneum. And therefore, when you get midfoot spring ligament laxity, you're generating a forefoot opposing moment to that soleus. And eventually, that center of pressure line will transfer far laterally, and along with failure of the medial column will cause the lateral column to destabilize. And I feel when the lateral column destabilizes, you're in a more advanced stage of PCFD than just when the medial column destabilizes. The zone of instability is now spreading to the lateral column, to the ankle. But when the spring ligament fails, it's very difficult to detect. It's not a painful condition. And one of the reasons might be this. So we did a study where we looked at the force required to generate a heel lift. And when you use the plantar fascia sectioning as a baseline, we needed a certain amount of force to generate a heel lift. We then sectioned the spring ligament, destabilized the first ray, and then sectioned the lateral plantar ligaments. And what we found universally in virtually every cadaver is when you section that spring ligament, the force required to generate a heel lift actually decreased. So spring ligament in isolation doesn't necessarily cause tendon reactivity because you're not actually overloading them. It's when you destabilize that first ray, you get a massive upswing and a statistically significant increase in force required. And although we didn't test tib post, it may be that the spring ligament is actually a silent situation, waiting for that first ray to fail, causing that reactivity. We did this using cadavers and a custom-made jig. I'm not going to go into that. So the spring ligament laxity allows medial talar head subluxation and talus internal rotation. And where does that occur? And it occurs 2 points. It occurs congruently early in stance, where the whole talus and the tibia internally rotate, and it occurs incongruently, where the talus internally rotates excessively within the ankle mortise itself. And that's actually underappreciated. It's very important to note that when you are going into toe off, particularly in accelerative gaits, you can have 10 times your body weight or force generated going through that stable first ray. And congruency of that tenovicular axis allows that huge axial force to be transmitted to the tibia to then generate a forward propulsive thrust. But without that congruence, what we're seeing is that weight, that force transfer is transferred to the middle column. And that's not important in itself, but when you transfer that force to the middle column, what you're doing with that tenovicular subluxation is generating a secondary vector, which is torque. Now you're putting a rotational pressure with cyclical loading on that talus. And when you look at an axial plane sequence, what's happening at the talus within the mortise, you have four principal constraints. You have that spring ligament preventing that talar head from swinging immediately. You have ATFL pulling it back into place. You have the constraint from the bony congruence and deep deltoid. And the problem is in PCFD, two of these constraints have got, you've lost your spring ligament and you've lost your bony constraint, which can constitute up to 30%. Now the talus is really principally dependent on ATFL and deep deltoid, and it has no muscular attachment, so there's no dynamic stability that's conferred. ATFL acts in tension, therefore deep deltoid will always fail in shear, and therefore you get this deep deltoid failure far before Johnson-Strom's stage 4 classification, where you get that valgus tilt and you get this anterior medial instability of the ankle that is detectable very commonly. And this talus internal rotation, there's been more and more papers coming out on it. And it's almost very difficult to appreciate radiologically, and it's often underaddressed in surgery. But this is the key paper by Kim et al. And they were able to take patients who had PCFD and look at patients in the sort of adult population, and they had this inclusion exclusion criteria. But in reality, they looked at PCFD was classified as patients having a tenovicular uncoverage angle of greater than about 20 degrees. And they were able to select 79 patients and divide these into two groups, moderate abduction and severe abduction group. And the severe abduction group had a tenovicular coverage angle of greater than 40 degrees. And then they had a control arm of patients who had no evidence of PCFD, and using selective tomograms that they were able to overlay, they were able to look at this angle, which is the transmetatarsal talus angle. And with internal rotation, this angle critically decreases. They looked at other angles as well, but this was a principal angle. And they were also able to look at the angle subtended by the medial border of the lateral malleolus and the lateral border of the talus. And any increase in this angle represented an increase in internal rotation of the talus. They also looked for degenerative changes within the medial malleolus. But the key measure was this transmalleolus talus axis, and what they found was a statistically significant decrease in that angle in patients with PCFD. So that talus is rotated even in moderate abduction patients. And when you look at the other angle, which is the angle subtended by the medial border of the lateral malleolus and the lateral border of the talus, what they found there was a statistically significant increase between control and moderates and severe. Again, proving that the talus is internally rotated, and probably very early on and underappreciated. And in all their patients, they found an increase in medial arthritis, and there's that pressure on deep deltoid because it's failing in shear. But I don't believe it's the whole story. And when you go back to sort of Kim's paper, and we realize with cyclical loading, you're applying internal rotation torque, and you lose two of those constraints, does deep deltoid always fail? And the answer is no. And what we found was that with ATFL laxity, deep deltoid doesn't fail. So when you clinically test for deep deltoid failure, that's with a heel external rotation test and an anterior medial draw test, they're quite solid on that medial side, and they have significant anterolateral instability. And when you go back to Kim's paper, and this is the key diagram, and you look at the controls, and you look at that lateral side, in the control group, you see a certain degree of anterior position of the talus compared to the lateral malleolus. And in the moderate abduction group, it's roughly the same. But in the severe abduction group, you can see there's a significant anterior translation. And that's in picture C of that talus on the lateral malleolus. And if you look at the medial side in C, it's congruent. But in B, the medial side is incongruent and the talus is almost shifted posteriorly. So there are different patterns, and that's that key anterior translation. And what we did was we took cadavers to test this, and we took 6 control feet and 6 paired feet. And with these paired feet, we're able to induce planus bisection, spring ligament, superficial deltoid, plantar fascia, and destabilize the first ray. And we randomized those paired feet to ATFL sectioned or ATFL intact and cyclically loaded them to 2000 cycles. And this is the thing I want to share with you. So if you take these feet and you take the control feet with cyclical loading, you are seeing a very small increase in strain in deep deltoid as measured by anterior medial separation. And what we found was in the group that had planus induced with the ATFL intact, that deep deltoid strain rate massively increases. And that's why you see the shear failure of deep deltoid. But in patients where we cut and sectioned ATFL, the deep deltoid strain rate almost comes back to the control level. So with spring ligament laxity, the lack of ATL is hugely protective of that deep deltoid and almost brings it back to original levels. So ATFL laxity does protect against deep deltoid. And what we found was that patients with planus with ATFL intact, deep deltoid strain was about 3.5 micrometers per cycle. And the reason for this is we believe that the talus rotation hinges on ATFL, which acts in tension and is favorable, and deep deltoid fails in shear, compared to when ATFL is absent, where the hinge is on deep deltoid and the talus is able to anterior translate out. And the relative strain that's developed is 0.6 micrometers per cycle, which is almost the same as the control. So if we know that spring ligament is important, can we test for it? And I just want to share this video quickly. It's about 30 seconds. And it's the left foot that you just want to observe. And I don't think there's too many toe signs, but he's able to comfortably go single stance, leg raising on the right. It's a bit more hesitancy on the left. But when you take the heel off the ground and you control the heel for pronation, i.e. put the heel into neutral or varus and prevent heel external rotation, what you see is this massive abduction swing. And that is what we call the neutral heel lateral push test, where you neutralize the pronatory forces and you can test for that abduction. And the problem with testing for it when we went through it was when you look at the anatomy, there's almost 26 different papers looking at the anatomy of deltoid spring. And part of the problem is there's different names for the same ligaments. Some ligaments are omitted. There's variability of sizes of bands that are described. But the key paper I think you should be alluded to is by Kentaro Amahar. And what he did was able to reflect the capsule, superficial deltoid, and spring as a single structure. Looked at it from the inside, it's actually a single reflectable interconnected structure with no different bands. And those extrinsic outside bands are just representation of forces that develop in that. So when you look at superficial deltoid spring anatomy, it acts across this big giant ligament actually acts across 3 joints: the tibiotalar joint, subtalar joint, and the tenonavicular joint. And it's a trapezoidal structure in the majority of people. And if you looked at a world without superficial deltoid spring, what would we see? We'd see that the tibiotalar joint is still constrained medially by the deep anterior and posterior ligaments. The subtalar joint is still constrained by several ligaments, but it's that talonavicular axis that has no medial constraint. So if you want to examine for spring ligament laxity, the best place to do it is to look at the talonavicular axis. And we were able to, I'm not going to go through this in detail, but selectively section loaded, unloaded tendons in retrograde and prograde fashion. And it's only when you divide the spring ligament, you get this massive abduction swing when you control the subtalar axis and the tibiotalar axis. And therefore, we came up with this, saying applying a small force with the hind foot in neutral, generating a 1.5 centimeter translation at the hallux, really is attributable to spring ligament failure. And you can compare different feet and notice subjective firm and non-firm endpoints. And I'm glad to say there's increasing amounts of validation studies that are coming out, and Slivova was able to show it has a good intraclass coefficient of greater than 0.8. And the basis of the test is when you control for pronation, you're using the first metatarsal and the talonavicular axis. By taking a small strain that develops in spring ligament, you're able to use that metatarsal tenovicular axis to amplify that strain to generate a large degree of shift at the hallux. And that's what we're looking at, a visual interpretation of strain that develops medially at that tenovicular axis. And this, we feel, can only occur due to defunctioning of that spring ligament. And therefore, you have to introduce the concept of this stage 0 disease of ligament failure, I believe. And when you look at the plantar grade foot and you look at Jennings' study, he showed that spring ligament failure does cause those peritalar rotations, but no visible deformity. That's exactly what's happening. When the foot is on the ground, that medial spring ligament has failed, but there's no visible deformity. But when you take it off the ground, you get that massive abduction swing as the talus swings through that poorly defined spring ligament. And the first ray ground reaction force will always put the foot back into neutral. But in the absence of spring ligament, and as the first ray fails, the foot progresses into this planus, and then the tib post comes in to try to counteract it. So why address the spring ligament? Well, it's the primary, it's the internal primary restraint to foot pronation. Externally, we look at the first ray as a primary restraint, but internally, the spring ligament also acts as a primary restraint, and it allows that realignment of the subtalar axis to a more anatomical position. And you've got to remember, bony fusions and osteotomies are not a substitute for spring ligament reconstruction, as a spring ligament reconstruction is not a substitute for realigning your bones. And there's no specific guidelines. The options really come down to non-anatomic, anatomic, spring, delta spring, allografts, autografts, and synthetics. Is there any evidence that one is better over another? And I'd allude you to this paper by Gavin Hayes, Malloy, and what they were able to do was look at a retrospective level 3 evidence review of patients who had had a synthetic reconstruction with an internal brace compared to a hamstring allograft. They weren't like for like reconstructions, but what they found was that radiographically, the synthetics did better compared to the hamstrings, and clinically they did better in the patient reported scores. And that's despite that circle at the top right showing that the synthetics had far less medial displacement osteotomies. They had functional better outcome with the synthetics. And again, it's not proof, but it's heading in that sort of direction. And if you look at the allografts, there's multiple options out there. You can use tendon allografts, and this is one by Brodell, who reconstructed spring and delta spring. And this is one by Robinson, where they used the stump of tib post to reconstruct that spring ligament. But really, people have moved on to synthetics, and the advantage of this is it restores sling function, allows that derotation and that reduction of that talus, and it avoids talus tunnels, screws, and washers, and precarious placements of these. And we're able to try to look at which one of the reconstruction is the most important. And there's several out there, but this one we looked at. And what we did, crucially, I think, was looked at whether a simple repair was better than a reconstruction, and which part of this well-defined reconstruction was the most important. And by sectioning these and applying an abduction force, what we found was that reconstruction was always better than a repair. And even if you think a repair is good, what you're trying to do is put back failed tissues onto itself. And what we found was that by sectioning that dorsal ligament, we found that the plantar ligament was still able to preserve abduction plane laxity. But when you sectioned the plantar ligament with the dorsal intact, the dorsal limb had no effective resistance. But there's multiple options, and what you're trying to do is resolve this vast ligament into a single linear construct, which is really impossible to do. And it can help aspects of it, but you're not going to solve all of it. And the ideal reconstruction is to put 20 different reconstructs covering the whole span of that ligament. But these are some of the common constructs to come off the medial malleolus and to go off the top. But we know this shouldn't be your primary option, because in mid-stance, when the talus is maximally internal rotated, these fibers are slack. So that can't be your primary option. When you come off the medial malleolus, at fixed bone points, you have two options. You can either come off the medial malleolus or the sustanticuli, and you come down to the inferior part of the navicular, and they're both good options. And that's commonly used as an adjunct. And we know that the problem with using this limb, where you come off the medial malleolus, is if deep deltoid has failed in shear and you're tensioning that, you're going to translate that talus posteriorly and allow some abduction laxity to happen. In effect, you defunction that spring ligament. It has to act across two joints. And that limb is actually perpendicular to the plane of the talonavicular axis, and therefore resolved will have very little function in the axis you want. And therefore, and we know that limb has very little benefit. So your money shot, if you're going to use one limb, is that. I can only tell you what I do. I use a 2-planter construct. If it's big enough, I do a 4-planter construct. I double up. Some people do put it down into the medial cuneiform. I have reservations about doing this, and the reason is that there's a lot of studies now showing, particularly using finite element modeling, that if you decrease the navicular cuneiform motion, you massively increase strain across the spring ligament. And therefore, I think reconstruct is better than repair. Augmented reconstruction is better, and the plantar rim is the most important. And the problem with trying to compare these is that you have so many confounders. But research is going to come out showing what is the best. So it's not, if when you look at stage 0, 1, and 2, and this is ligamentous staging, and it's nothing to do with the PCFD staging, it's important to restore tripod stability, but redirect that subtalar axis. But I'm just going to quickly go back, and I've almost finished. If you basically redirect if you introduce stability in your first ray, it doesn't matter if your spring ligament is lax and your subtalar axis is internally rotated. You're still going to generate an eversion vector. What you need to do is, and that's if you plantar flex it, it's still going to act against you. What you need to do is reconstitute that spring ligament to reconstitute the subtalar axis, and therefore generate a net inversion ground reaction force. And the calcaneal osteotomy is important. And doing a heel shift, you get several benefits, but again, you're improving your ground reaction, your inversion pull around the subtalar axis. My last slide. Deep deltoid instability is very hard to control, and you've got to remember anterior constructs are not going to stop that internal rotation. And in the future, should we be reconstructing ATFL? I think we probably should. And should we be preserving tib post? Yes, because it's an external rotator of the tibia, unlike FDL, and it acts to externally rotate that. So in conclusion, spring ligament laxity, I believe, is a route to development of PCFD. There's patterns of internal rotation failure of the talus that are emerging. Restoring that subtalar axis is critical to foot function after restoring the tripod stability, and it should be part of modern treatment plans. I'm going to get you out on this. And this is a quote from John Lennon, and I believe this is true. The more I see, the less I seem to know for sure. Thank you.
Thank you very much, Chandra, for a very interesting talk, and I'm sure there will be questions will follow. So let me now introduce to our second speaker. So Chandra, if you can unshare.
Yeah.
So our second speaker is the first we have got on Master Techniques from USA over the pond, but obviously online. And thank you so much, Cesar, to be with us. And I know it's time difference, so you had to cut down your commitments and to be with us. Dr. Cesar Netto, he is an associate professor at Duke University. He's also the president of the Weight Bearing International CT Society. He's editor-in-chief of Foot and Ankle Clinics, and he has several research interests, but I think the one which is close to his heart, he has done a lot of work on progressive collapsing flatfoot, and he's one of the pioneers for the new classification, which he's going to share with us. So, Cesar, all over to you.
Oh, thank you. Can you guys see my screen there?
Yeah.
Okay, good. Well, first, I appreciate the invitation. It's a great pleasure and a great honor to be here. So, thank you, the organizing committee and BOFAS for the invitation. I do have conflicts with every talk of PCFD because of my relationship with Curve Being and other companies with weight bearing CT. And It's always great to be with my British friends. I just did a road trip with my family through the north part of the UK, and here are some pictures recently with some British friends, including the British Mafia and AOFAS on the top left there, as you guys can see. But always a great
Cesar,
pleasure.
sorry to interrupt. Your slides are not moving.
Oh, really? Oh, let's
Now,
do it again.
yeah, that's good.
Okay, let's stop and do it again. So I was showing some stuff and you guys couldn't see it. Let's do it again. Can you guys see now?
Yeah.
Let me see if it's moving. Is it moving?
Yes.
Okay, I apologize for that.
No problem.
Here's the pictures. So this is the British Mafia and AOFAS, if familiar faces for you guys there. So it's always a great pleasure to meet you guys and to visit. So again, appreciate the invitation. So I think you guys asked me to talk a little bit about the classification, and I gave a similar talk at AOFAS this last meeting. So tell a very brief little story behind the consensus meeting that happened in 2019, just before COVID hit. With some experts on the field. So I was one of my fellowships in the U.S. I had the pleasure and the honor to train under Dr. DeLand and Dr. Ellis. They are two of the most published authors on the subject. I always had my passion for Flatfoot. I had some work even before arriving there during my research time here in the U.S. And then it was a great opportunity for me to learn from them and to come up with some ideas. And one of the ideas that we had was that based on some information, and I think this is one of probably the most important slide of the talk. And Part of the concepts that were introduced, or I would say expanded, I don't want to say introduced, but expanded with weight bearing CT regarding bone alignment. And we just had a great talk about spring ligament as the possible, initial factor for PCFD. I think is highly controversial. I can't disagree with a lot of what was said there, but I'm not sure that we can narrow down to one single structure, unfortunately for us as surgeons. But I think the concept peritalar subluxation is very important. It swings the pendulum back to the bone alignment a little bit more. But these concepts of peritalar subluxation is basically the foot subluxing under the talus in PCFD with a malalignment of the subtalar joint, where you could be born with a more inclined valgus subtalar joint that we are seeing here on the posterior facet. The presence of subtalar joint subluxation that you can assess by looking into the posterior facet here or the metafacet here, metafacet subluxation, posterior facet subluxation, as well as indirect signs of peritalar subluxation. Most importantly, sign of starch impingement, that is basically the lateral process hitting the calcaneus and the calcaneus hitting the fibula, are important concepts that we thought needed to be introduced in the literature, and they were not really utilized in the classification. So we started thinking about it. We exchanged emails. We did a full review of the literature. And it was tough, very hard to make decisions on that regard of who to invite for an in-person meeting. So we sent invitations out. We actually sent a full questionnaire ahead of the time to talk about multiple things. And because the lectures about the classification, we asked the experts that we invited, do we think the classification is outdated? And then should we discuss a new classification system? And it was 100% agreement that that was the case. And then the meeting finally happened in November 2019. A lot of people ask me, how did I feel during the meeting? That was me there, right? No one close to the other people that were in the meeting. We all had talks about specific subjects, and these are just some pictures from the day of the consensus. There it was a great meeting, and one of the things that we discussed was about the classification system. So we came up with this after discussing all the topics. So we discussed pretty much every single topic in 2 days. There's a total of 16 hours of recorded meeting. And we came up with this proposal, and we voted to once we were done with the meeting, for agreement between the experts, and we had 100% agreement to get that out. A lot of manuscripts came out in Food and Ink International a year later, in October 2020, including the one where we recommended this change in the nomenclature And the reason for that is multiple. So we didn't want the adult there, and we didn't want the acquired, because a lot of patients, they had flat feet their entire life. They just started becoming symptomatic when they're adults. And of course, it can happen during late childhood or adolescent, teenager times and early adulthood. Flatfoot is, we think it underestimates the problem. The arch collapse is just one of the many deformity patterns or deformities that we see in a PCFD. And as we had in the prior lecture, like the posterior tibial tendon is just the tip of the iceberg. So we came with this progressive collapsing foot deformity. Again, it's okay to have a flat foot. It's not okay to have a flat foot that is getting worse. That could be progressive collapsing foot deform. So basically, it would be the pathologic flat foot. And if you look into the classification, the only thing that really changed first, we didn't like the idea that the prior classification systems, like stage 1, 2, 3, 4, gave an idea that you would have to go through 1 to get to 2, and then to get to 3, and then 4. This sequence doesn't really happen in patients. And we thought that basically the only 2 stages that would be sequential would be a flexible deformity becoming rigid deformity chronically. So you would have to be flexible first to be rigid, unless you have something else like a tarsal coalition or something that would explain a rigid flat foot to begin with. And then we did not reinvent the wheel. If you really look into the classes that we call deformity classes, it's basically getting everything that was already in the other classification systems and things that are important for providers to look into. Uh, and adding that as classes of deformity. The only new thing was peripheral subluxation, that would be the class D there. And then we wanted people to be able to look into the feet, look into the patient, and be able to describe what they see based on the presence of these deformity patterns. So the idea of the classification was always, you look at the patient and you tell me what you see, and then I will be able to understand what you're talking about. So basically, if you see hindfoot valgus, you would put a letter A there. If you see midfoot or forefoot abduction, it's controversial. Some people prefer forefoot abduction. Some people prefer midfoot abduction. So we put midfoot, forefoot. So we didn't get into too much discussion on that. But if you see midfoot, forefoot abduction, you would put a letter B there. If you see collapse of the longitudinal arch, that was previously described as medial column instability, forefoot varus when you correct the hindfoot, super controversial. I think the class C is the most controversial one in my opinion. But medial column collapse or arch collapse would be class C. Then you put a letter C there. If you see peripheral subluxation, that is not easy to see with X-ray. You can have indirect signs of it, but you would put a letter D there. And if you see a valgus deformity of the ankle, then you would put a class E there. So you basically could combine those letters, and every single deformity class can be 1 or 2, flexible or rigid. And we're going to play with the classification a little bit. We did look into the reliability or the of the classification, intra and inter observer reliability. We published this in Foot and Ankle International a couple of years ago, and we described the frequency of the classes. So class A most frequent, followed by class C, that would be the collapse. Class B would be the third one, 76% of abduction. Class D, less frequent, also because people are not very, I would say, gauged and used to look into that kind of deformity. And class E, as expected, the ankle deformity less common. In the combinations, we found that A1, B1, C1, or 1 ABC with valgus abduction and collapse was the most common one, followed by AC, that is valgus and collapse, and then followed by 1 ABD, valgus abduction, collapse, and peripheral subluxation. But again, the idea of this classification was never to be super high reliability. The idea was, if you tell me you have a 1 ABC, doesn't matter where you are in the world, you would be able to understand what that person has in front of them. And when we looked into the inter-observer reliability, as expected, Class D was the lowest numbers, because you can't really see what you're not used to see. So Class D still creates a lot of a controversial discussion. And Class C, as I said, I think it's tough. Particularly if you think about dynamic positioning of the forefoot once you correct the hindfoot, that's also controversial and debatable. And so that was the second lowest reliability that we found. But overall, the intra-observer reliability for the full classification was 0.85, and the inter-observer 56. That is not a very good reliability, but again, that was expected when we came up with the classification. So people ask me, and I would be glad to discuss in the end here, is like, is the new classification, PCFD classification, decisive? Of course, I'm biased, and I'll say yes, it is. And the reason for that is it allows any provider to describe what they see. Yes, what you see might be different than what I see. But if you tell me what you see, I would be able to imagine what you have in front of you. And that's the reliability part. And that the deformities can happen concomitantly and they don't have to be sequential. And that was a big mistake of the Johnson Strom, Meyerson, and Meyerson modified by Blumen and other classifications in the literature. So it helps you to think into what are the deformity patterns that you have present in that specific patient, and helps you to think about how you would correct those. So, but if you want a cookbook, that's not going to be it. It's almost impossible to have a cookbook or a classification that will give you exactly what you have to do for each patient. Why? Basically, because surgeons approach the deformities completely differently, and it's just too complex of a deformity for a cookbook to work well. So it gives you an idea, but it's not going to give you the exact treatment that you want to have. So that will never exist. Doesn't matter how much research we do on this. And I do want to acknowledge some stuff because we're going to go into some cases to play around with the classification. And I want to keep in mind that we do live in a 2D world, right? And that includes ourselves, the surgeons. So when we see this hindfoot valgus, we want to do a medial displacement calcaneal osteotomy. It doesn't matter what else you see. You just say, I'm going to shift this heel. And then you see this, you see abduction of the midfoot or forefoot or talonavicular uncoverage, and you already think, I'm going to do a lateral column lengthening there or spring ligament reconstruction to correct that, or both. We always think plane by plane. And then you see collapse like this, and you say, I'm going to do a cotton, or I'm going to do a lapidus, and I'm going to bring that first ray down. So we always try to compartmentalize things in different boxes, in different planes. However, we forget that the foot is a three-dimensional structure with uh, 28 bones and multiple joints. So when you change the position of any part of the tripod, the entire foot is going to readapt to that position. So when you move your heel, you're not just changing hindfoot valgus, you're changing the entire thing. When you bring your first ray down, as we teach for cavo varus, like a forefoot driven hindfoot varus, you bring your first ray down, you're going to generate varus in the hindfoot. So yes, we live in the 2D world, but we have to transition into 3D if you really want to understand PCFD. So let's use cases to play with this. So I'm going to go relatively quick through the cases. It's not the idea to go to the bottom of my choices here, so you guys can criticize. But this was a 33-year-old female, again, very young patient with complaints on the left foot. She always had some flattening of the longitudinal arch, but she started getting worse in the last couple of years. She had a pop. She felt a pop while doing some martial arts a couple months before she came to see me. You see the hindfoot valgus that is asymmetric. You see a very unstable first ray. You can actually see the first tarsometatarsal joint popping in and out there. You can do any measurements that you like to do. I put some measurements here. Talus first, calcaneal inclination, talonavicular coverage, talus first in the axial plane. You can look into your ankle joint. There's no visual valgus there. You can look into your hindfoot alignment angle. You can see I measured 32 degrees and 28 of hindfoot moment arm. What is going on in the subtalar joint? What is going on in the subfibular area? You can't really tell with the hindfoot alignment angle, unfortunately. So I did an MRI. You see that the posterior tibial tendon in this young patient was not good. There was a lot of inflammation around it. If you kept going distally, you saw that it was actually ruptured. So probably that was the pop that she felt. There's some degeneration of the interosseous ligament there. You can see a very horizontal cervical ligament. And then when you look to those signs of peritoneal subluxation that we discussed, that I showed you guys in the beginning, she had a 25 degrees angulation of the posterior facet on the midpoint of the subtalar joint. She had signs of posterior facet subluxation. She had sign of tarsi impingement. She had medial facet subluxation. And even though the heel was not hitting, remember weight bearing CT is weight bearing, but it's still static. It's not dynamic. So maybe she was hitting this calcaneus on the fibula when she was walking. We won't be able to be sure here. Again, sinus tarsal impingement, you can see a little bit of translation of the first tarsus metatarsal joint. Maybe you can make argument for a little bit of gapping on the plantar side of the first EMT. I measured my medial facet subluxation 59%. I love the forefoot arch angle for collapse. We can talk about that later. 4.2 degrees, and normal is in between 15 to 25. So significantly collapsed. And I use foot and ankle offset a lot. She had, look where the center of the ankle joint is, look where the bisecting line of the tripod is. So that gives a foot and ankle offset of 11. I do my fancy distance and coverage maps that we publish on. So basically looking into three-dimensionally. So 41% of the sinus tarsi was covered. That means the normal goes up to 5%. So it was a lot of sinus tarsi impingement, sinus tarsi coverage. She had 55% coverage of the medial facet, 78% coverage of the posterior facet, and pretty much a completely dislocated. That number is wrong there, so I apologize. Completely dislocation of the anterior facet. So if we play with the classification, do you see valgus? So I think you all would agree that there's valgus there. So yes, and it was flexible. So that's A1. Do we see midfoot abduction? Uh, I would say yes, we measured, and yes, it was flexible, so that B1. Do you see collapse of the longitudinal arch, medial column collapse? Yes, and it was flexible. I'm telling you, it was flexible when I assessed. So that's the C1. Do we see peritalar subluxation? She had multiple signs of peritalar subluxation. That's yes, it's flexible. D1. Do you see valgus deformity of the ankle? No. So there's no E. So it's a A1, B1, C1, D1, or A, B, C, D. So what to do with this patient? Should we let it go? Should we continue to treat conservatively? Should we do surgery? If we're doing surgery, what are we going to do? So basically, like I said, the deformity classes can give you an idea of what to do. So if you say that there was valgus there, you can think about automatically you think about a medial displacement calcaneal osteotomy. But remember, an FDL tendon transfer, a lateral column lengthening, a first-rate procedure, either a cotton or a lappy cotton, bringing the first rate down, and a subtalar joint fusion could correct hind-foot valgus as well. So it's not just the medial displacement calcaneal osteotomy. Do you see the midfoot abduction? We said yes. So automatically you think about lateral column lengthening. However, again, FDL tendon transfer, spring deltoid ligament reconstruction, a first-rate procedure, they all are going to change abduction as well, not just the lateral column lengthening. Collapse, we said there was collapse. So you can do cotton, automatically come to your mind. But a lapicoton, an NC fusion, of course, a talonavicular joint fusion that we wouldn't think here, hopefully. Also, there's some literature now for an FHL tendon transfer to the first metatarsal. You mentioned Jay and Keene, he published on that. Could also change the collapse of the longitudinal arch. And what about peritalar subluxation? We said that it is present. Every single procedure that you do will influence your peritalar subluxation. So there's no one single procedure that will change it, and the other ones would not. So peritalar subluxation is the influence for by everything that we do. Of course, if we had more frequently, maybe for example, reconstructing the interosseous ligament, for sure, spring and deltoid reconstruction changes peritalar subluxation. Also, there's a lot of attention now for cervical ligament reconstruction. Those would also change peritalar subluxation. So what I did for this patient was a gastrocnemius recession, a medial displacement calcaneal osteotomy of 11 millimeters. I did a lapicoton with a 10 millimeter wedge. I did an FDL tendon transfer. I did spring deltoid reconstruction. I did bone marrow aspirate. I'm not going to go into the details here, but this is the final x-ray for her intraoperatively. And this is the video of her from before surgery to 12 weeks weight-bearing CT. So you can see the foot derotating and the peritalar subluxation being corrected. And again, remember, I did not do a lateral column lengthening. So look at the correction of the talonavicular coverage without a lateral column lengthening. So again, you don't need a lateral column lengthening to correct abduction, as brilliantly demonstrated in the prior lecture as well. This is the patient with 18 months showing that she maintained correction and was doing good. I'll go very quickly through the second case. Completely different 76-year-old female with this X-ray. You can see a lot of abduction of the talonavicular joint. The ankle is spared. There's some arthritis in the ankle. There's collapse. There's sinus tarsal impingement. Here's the clinical picture from the weight-bearing CT where you can see the abduction, the hindfoot valgus. I measured her foot and ankle set. Look where the center of the ankle is. Look where the bisecting line of the tripod, the collapse, the amount of peritalar subluxation completely dislocated, hidden on the fibula. And then if we're classified, there's hindfoot valgus, it was rigid, so that's A2. There's midfoot abduction, yes, it was flexible in my opinion, so that's B1. There was collapse of the longitudinal arch, there was yes, it was flexible, so I put a C1. There was peritalar subluxation that was rigid, so I put D2, and there was nothing in the ankle. So that would be a A2, B1, C1, D2, or 1, BC, 2, AD. And then I did a subtalar joint fusion. I did longus, brevis to longus tendon transfer. I did a Lapicotin. I did an FDL tendon transfer to protect my subtalar joint, sorry, my talonavicular joint, and I did a spring deltoid ligament augmentation. And this is the patient x-rays demonstrating the correction, and the weight-bearing CT post-operatively showing the amount of correction we were able to get. You see that now the talus, the center of the ankle, and the center of the tripod are exactly on the same line. You see the medial facet corrected with the subtalar joint fusion. And this is the patient with 6 months demonstrating preserved correction there. So again, it is decisive. However, don't wait for a cookbook because I don't think any authors or group of experts will be able to give you guys a cookbook. This is just too complex, too three-dimensional for us to be able to nail it down to an exact treatment option. We do have some extra meetings happening, and we have some other people that joined the team, and then we're working on some updates on the classification and some next steps for treatment, and that should be coming to the literature very soon. Again, thank you so much for having me, and it's a great pleasure to be here.
Brilliant. Really, really interesting talks tonight. Lots of, unconventional thinking outside box sort of approach. So let's start the discussion. So first question, Cesar, you gave the talk. Can I ask you, and this is to understand what I, so the new classification, A, B, and C, as far as I can see, you can see it clinically. You don't need any investigation. Whereas for D, you need a CT or a standing CT. Is that right?
Yeah, great question, Manish. Not necessarily. Yes, if you have a weight-bearing CT, it's easier for you to gauge that and to measure it. But you have indirect signs of peritalar subluxation, and the HSS group. I think maybe Jay and Kim was also the first author for that one, but they also publish on uh, deformities that can be seen in the X-ray that indirectly correlate with peritalar subluxation. So you can see it on the X-ray. I would say, for example, sinus tarsus impingement is a sign of peritalar subluxation. So the presence of sinus tarsus impingement could be the interpretation of peritalar subluxation right away. Uh, as I think Chandra showed, if you really think about it, there's no way that the subtalar joint is subluxing with the talonavicular joint staying in position. So they happen concomitantly. So I believe, if I remember correctly, that the HSS papers show that the talonavicular coverage is the one that predicts the best the presence of peritalar subluxation in a weight-bearing CT, as one would expect. So uh, the answer to the question is yes and no.
Okay, fair enough. Chandra, so what causes spring ligament dysfunction? Sorry, we can't hear you. Are you muted? Can't hear you, Chandra. Now I think, yeah. I'm speaking now.
Hello?
Yeah, we can hear you now.
Not sure. You can hear me now?
Yes.
Yeah, perfect. Yeah, so it's a really good question. It's very important, actually, because we're sort of finding out more and more about different ways the spring ligament fails. And so when you look at the spring ligament, it's supported superiorly by superficial deltoid. So you have significant amount of fibers of tibio spring ligament that insert onto it. So when you look at patients, and we've looked at patients who've had supination adduction injuries to their ankles. So these are patients who've had no pronatory forces, but the foot fractures the medial malleolus and supination adduction stage 2 injuries in inversion. So when you look at these patients, and we've only had a few of them, and we've looked at these, what we found was that even if you restore the medial malleolus in some of these patients, when you compare talar navicular abduction on the injured side compared to the contralateral side, we're finding a lot more laxity at the sort of talar navicular articulation. And therefore, when you're talking about the spring ligament, you can't talk about it in isolation. And the mechanism of that injury causing that increased talar navicular abduction must be from the fact that superficial deltoid and capsule has ripped off that medial malleolus and therefore has decreased the tension on that spring ligament and therefore allowed for that talar navicular subluxation to occur. And therefore, we've now got to think of spring ligament laxity in two terms. One, intrinsic spring ligament fiber laxity. And the second is when superficial deltoid fails, you also get spring ligament laxity within itself.
Okay.
So I think, yeah, there's 2 points. And then if you're looking at sort of within the spring ligament itself, it's just multiple factors. It could be age, collagen degradation, just sort of repetitive use, hyperlaxity that might be pre-existent, BMI, etc., that intrinsically cause laxity in that spring ligament or significant tears. And we've sort of, we've got a paper on the review and we're trying to classify that as type 1 and type 2. Type 1 spring ligament laxity is where it's defunction secondary to superficial deltoid, and type 2 is intrinsic pathologies within the spring ligament itself, because they may be able to be treated differently. One by sort of pulling the superficial deltoid back in place, and the other by tightening spring ligament.
Thank you. There are quite a lot of questions coming from the audience. So the first question, which I would like to ask, both of you can answer. How do you decide how much medial calcaneal shift to do in view that there is a large normal variation in the lateral moment? So Chandra, you can answer first, perhaps.
Yeah, so the answer is, so when you look at calcaneal anatomy, if you look at the sort of average diameter of the calcaneum, this is from sort of anatomical studies, what you're finding is the average diameter is about 3 centimeters in total. So you can get a pretty good shift. And if, so Mark Meissen typically described it, I think, as 1 centimeter, but then you can go more. And you really want to get that calcaneum back under that sort of ankle joint, and you want to decrease that sort of valgizing ground reaction vector at heel contact. So the maximum I feel you can go is probably somewhere between sort of 1 to 1.5 centimeters. I think beyond that, you're going to lose contact area to actually get enough healing to happen. So yeah.
Cesar?
Yeah, I agree with Chandra. I mean, I do weight bearing CTs, and I think I saw in the, sorry to jump into another question there, but I do weight bearing CT for all my PCFD cases before. And I know I'm blessed to have that available, and I know it's not available everywhere or randomly available. But I use the foot and ankle set and other measurements to plan my surgery. The foot and ankle set actually gives you exactly the amount of displacement that you would need to correct the entire deformity through an MDCO. Of course, that's not possible. Sometimes it tells you that you have to displace the heel by 2.5 centimeters. That is impossible. But that gives you kind of a gauge of how much you would have to shift. But if you don't have that, I think there's enough data in the literature, again, coming from HSS, where basically what you're trying to do is to have a neutral heel intraoperatively, where your heel is aligned with the leg and you can elevate your leg and look at it. And then what that showed using x-rays is that when you have a neutral clinical heel, you have radiographically slight varus, like a little bit of varus. And Dr. Ellis has shown it before that when you have very mild varus in the hindfoot moment arm. Those are the patients that did better when they looked into patient-reported outcomes. So I think that's a good idea for you to shift as much as you think you need. Put a provisional wire, look at it. If you did too much, go back. If you need a little bit more, try to push more. So I think you can still do that clinically, and be very precise.
Thank you. Thank you. Another question is about when do you is age a criteria to say whether we are going to do deformity correction without fusion and you start thinking about fusion, or is it all physiological? Age is not a criteria, look at the joint health. That's a question from one of the audience. Cesar, you can go first.
Yeah. Well, I'm not here to be to ignore the age, right? And say, yeah, I don't even consider the age. I would be lying. But it's not part of my first five algorithm bullet points. I think if you have a good joint that is not arthritic, and the majority of the joints are not arthritic, people make a big confusion. That's another big difference between the prior classification system and the PCFD classification system. If you look into the Myers and Blumen classification, they talk about sinus tarsus impingement, describing that as sclerosis on the sinus tarsi as a sign of rigidity, and that's not true in my opinion, because it's a rotational problem. You can have sinus tarsus impingement, could be bad sinus tarsus impingement, and you do a joint preserving correction, and the sinus tarsus impingement will be gone, and you spare that joint, and patients do fine. So the age, if they have a good joint, if they're flexible clinically, if they have a good inversion strength, uh, or if they have the possibility of repairing the inversion strength with an FDL tendon transfer or an allograft reconstruction, those things are more important for me than the age itself. But there are some patients that come to you and they are one and done type of people. They're 70s, they're just retired or retired 5 years ago. They want to enjoy life and they say, I want the solution that will give me 10 years. And after that, I'm ready to go. And then in that scenario, you have to respect what the patient wants, but the number itself is not primordial for me.
Chandra, do you want to add anything?
Yeah, and I completely sort of concur with that. When you see these MRI scans, when you do see some edema laterally, it's not a contraindication for me to do or not do a flatfoot reconstruction, because again, as I said, that impingement, that edema you see laterally doesn't mean that the ankle is degenerate. So from my side, again, age is not a thing per se, but it's everything. It's the physiology of the patient. Has the patient medically well? Is he an active patient? Is he able to rehab afterwards? Is he able to stay in a PAP afterwards? So I think, and are the tissues going to be able to take that reconstruction? So if you've got a very sort of osteoporotic bone, you're going to struggle to get your bony anchors into. You're going to struggle to get sort of good fixation. So it's not age, it's really their physiological age, not their chronological age, that you're really looking into in this. So if their physiological age is way ahead of their chronological age, I certainly would consider it.
Thank you. Chandra, you might have answered it in your talk, but there is a question about that you've nicely explained the basic science of flexible flat foot. Does this knowledge change your operative plan of type 2 flat foot? When would you augment FDL transfer with some kind of spring ligament plication?
Yeah, so the answer is
sorry, you're muted.
Sorry. It's made me think a lot more about the way I do things and way that things are probably going to go in the future in terms of sort of soft tissue management, because what I think PCFD is really a peri-talar problem. It's that talar swinging round, and we may not be able to see it early. And therefore, I still think that deformity is a secondary consequence of that soft tissue instability that's happening. And you might see that soft tissue instability very early. But in a stage 2 flat foot, I always do a medial heel shift. I always now do a spring ligament reconstruction, because in that terminal stance, you've got to be able to externally rotate that tibia. And there's only 3 ways you can get talonavicular congruency. And one is if you're considering a lateral column lengthening. It's not an operation I like due to multiple reasons. You can do it through a talonavicular arthrodesis, but you're going to stiffen that foot. Although you maintain congruency, it's the expense of that joint. And the best way of doing that is by doing a spring ligament reconstruction. I always do a minimum 2 plantar construct, but if the ST is big, then I will go for a 4 plantar construct with 4.7 swivel lock in that place. Do I always pass FDL? And the answer is yes. And I think the FDL is still going to provide some inversion power because I excise tib post in virtually all but patients. So when I assess these feet, there are multiple zones of instability. One is deep deltoid laxity that the tib post acts around. One is spring ligament laxity that the tib post acts around. One is medial column instability that the tib post acts on. And one is the lateral column as well, because tib post fibers insert far laterally. And if any of these, in my mind, are unstable, the tib post is going to react. And therefore, if you're not going to control these, I get rid of tib post. So patients who have isolated spring ligament laxity in a flexible flat foot, where the medial column is very stable, the lateral column stable, then I will not excise tib post to an FDL transfer. But in the others, I always do. I hope that's clear. But yeah, if the zone of instability is spread away from the medial column into the tibio-talar joint, into the lateral column, I will do a tib post transfer.
Thank you, Chandra. Cesar?
Well, I think I mean we would need another day here discussing with Chandra. It would be awesome. I think he's doing an amazing job. But I think I think this is the area that we disagree the most. Uh, um, is I agree. I agree with some points of what he's making. I think it would be great and very not easy. I don't want to say easy. I think the part that we agree is that the soft tissue is the main driver of things. I agree on that regard. But explaining the entire PCFD on soft tissue only, I think it would be too simple, and I don't think there's anything simple on this. I think it's a multifactorial disorder. That's why we have so many different deformity components. So develops in different ways in different patients. And I am biased towards the bony malalignment. And so I think maybe we'll never know what's the chicken, what is the egg. Uh, and then we also disagree on the spring ligament reconstruction. Actually, my data from patients, not from the great, beautiful cadaver studies that he did and the biomechanics, uh, but Dr. Deland also experienced with his spring and deltoid reconstruction is that, in our opinion, the most important one to be reconstructed is actually the tibial spring a part of the deltoid. I rarely do a formal spring ligament reconstruction. When I see deltoid spring, I'm basically doing medial mal to navic. I rarely put an anchor on the sustentaculum. In my opinion, without having the beautiful data that Chandra has, is the one that influences my correction the least. So it's the one that I do the least as well. Um, but again, there's no right or the cool part of all this is that there's no right or wrong, right? And I agree. I can't agree. I can't agree more with John Lennon and what Chandra put in his talk. The more we study this, the less we know. And just to throw even more controversial aspects on the discussion here, I actually think that the reason why the literature was so successful with the early publications from Meyerson and Lucian about MDCO and FDL tendon transfer solving problems is because uh, the spring ligament, sorry, the FDL kind of works as a spring ligament reconstruction, particularly if you're thinking about the deltoid spring, right? Because it's the exactly same trajectory of the deltoid spring ligament. Uh, and then when you do that loop under the talus, you're kind of reconstructing that part. So I think the FDL tendon transfer is more important for static reasons than for dynamic reasons of inverting the foot. So that's why I think FDL transfers are so successful. So for example, when I do an FDL tendon transfer, I don't do the tibia spring because I think my FDL is already doing that for me. I would do only a tibia and a Vic in that scenario. We go from the tibia up into the navic, but from top down and not from bottom up. But again, we would need a full weekend here, Chandra, to talk about this. But again, very
Definitely,
beautiful work, and
definitely.
Okay.
Thank
Now,
you.
I mean, there are a few questions. So, but in the interest of time, I was waiting for this question. I knew you will come, and there's somebody who's asked this question. So, both of you, you can have your say. What is your opinion on the role of arthrodesis screw?
Who do you want to go
You
first?
go first.
Yeah, okay. Okay, look, first thing to say is I don't use it in my practice. And the second thing to say is I think it has different roles in different populations. So in the pediatric population, it has a completely different role to the adult population. So when you look at the pediatric population, if you think of a patient with congenital hip dysplasia and you direct within the 18 months of that hip being subluxed into the acetabulum, you cause that triradiate cartilage to grow normally. So it's very important to redirect that. And I think it's the same in the pediatric group. If you take your acetabulum pedis and you redirect the talus into the tenovicular axis and put the middle facet back over the sustanticular talus, what you're going to do is make that grow better. And there's some evidence indirect evidence from Oxford that actually published this, I think, where they actually showed that patients with sort of flat feet in the early adolescent group actually have a smaller middle facet that develops compared to people that develop PCFD later. So the pediatric population, that the early adolescent population that develop a flexible flat feet, I think is totally different to the adult population that have been normal for years and then develop it because the morphology of their joints has completely formed normally. So therefore, if you're talking about that group of population that's skeletally now mature and you're putting an arthroraesis screw, the first thing to say is that is not a substitute for doing everything else. The second thing to say is I don't think it's an implant that can be used in isolation. I know there are reports out saying they've had single surgeon series that have had phenomenal results by just an arthroraesis screw, but it's not something that I would recommend or is it within my practice. So I have to say I've never used it. When would I use it? I'm unsure. I think if the soft tissues are terrible, you've done all your bony realignment, you've reefed everything, and that sort of talus is still swinging out, and you're getting that lateral sort of impingement, there may be a role of putting one in just to control that while the soft tissues are healing. But the problems I have with it is how long do you put it in? What size do you put in? It has a high complication rate in terms of repeat surgery, pain, etc. And when do you take it out? And I don't think there's any guidelines on that. So yeah, that's my opinion piece. Yeah.
Thank you. Cesar?
yeah, well, I agree. I agree with him. You know, I was trained in Brazil with the idea that arteries screw was a disaster, and I should never get even close to one. But after studying peritoneal subluxation and looking into subtalar joint subluxation, and seeing the results that some, particularly European authors, are showing with the arteries, it does, get my attention. And if there's one thing that the arteries screw probably does is correct peritoneal subluxation. So I'm entertaining the possibility of studying it in the lab and before I even jump into something. Uh, but I couldn't agree more with Chandra with everything that he mentioned about, for me, it would be great if I could do a 10-minute surgery instead of a 3-hour surgery. That would make my life much easier and my practice much more profitable. But again, we go back into the discussion of there's nothing easy and simple with PCFD, so it would be too simple to think that you would put a screw there and solve all the problems. I'll leave it there.
Thank you very much. I mean, look, there has been a lot of questions from the audience, and I'm sorry I can't take all the questions because we are late here. So I'm going to close this session off, but thanking once again both to Cesar and Chandra for your time, your effort, and really you have given a lots of food for thought. We don't know all the answers, as you say, but we probably start thinking about it in a different way from now on. At least I will. Um, Everyone, have a good evening, and thank you once again for attending Master Techniques. And we'll see you for our next uh, number 15 Master Techniques sometime in February. We'll announce the date and speakers. Keep in touch and have a good night. Bye bye.